So our next speaker is Dr. Gantner. He's an intensive care consultant at the Alfred Hospital in Melbourne, with academic appointments at the Centre of Excellence in Traumatic Brain Injury Research and the Department of Epidemiology and Public Health at Monash University. His research interests include neurocritical care, transfusion medicine, fluid management and resuscitation, and he's currently undertaking a study on the barriers to implementation of evidence in clinical practice in the management of neurotrauma. And he's going to speak to us on lessons from trials in traumatic brain injury.
Thanks very much, Katie, and thanks to everyone. I was reflecting in the lunch break that I can't remember a conference I've been to where the level of engagement on research methodology is as high, and that's including the ANZIC's clinical trials group, of which I'm a proud member. So I just want to express my gratitude to ACTA and to Rhiannon Tate particularly for giving me this opportunity. As mentioned, I'm an employee of Alfred Health, and Alfred is a ANZIC's CTG affiliated institution. You've heard a lot about the ANZIC's CTG this morning, and I'm also undertaking a PhD in the translation of research into practice and the management of traumatic brain injury. So it's fair to say that I have a belief that collaboration is a positive thing when it comes to development of high quality evidence and implementation. But I'm talking about traumatic brain injury, and just to remind you, it's prevalent and it's expensive. The global incidence of TBI is anywhere between 100 to 700 per 100,000 of population, and it's the leading cause of death and disability in young people. Unfortunately, it's increasing in incidence with more cars in low and middle income countries and more falls in the ageing populations of high income countries. And it's terribly expensive. The annual cost in Australia, indirect and direct costs combined, is 8.6 billion, which remarkably is higher than dementia, bipolar disease and multiple sclerosis combined, and it has a greater economic impact than workplace injuries. There is a perception that with improvements in the care of our patients, particularly in the intensive care, that TBI outcomes are improving, but unfortunately recent data from the Victorian State Trauma Registry doesn't seem to back that up. While I'm a believer in social media assisting in translation, I prefer that these data, which are currently under review, are not posted on social media, please. You can see that the in-hospital mortality is stuck at around 45% for severe traumatic brain injuries in Victoria over the last 10 years. But I would add the caveat that these are unadjusted data and that there have been some demographic changes in these patients. So the first lesson for me that I want to pass on to you is that the evidence to guide us in the management of traumatic brain injury is generally pretty low. This work conducted by my colleague and PhD supervisor Peter Bragg and published earlier this year in the Journal of Neurotrauma was probably the most comprehensive systematic review of randomised controlled trials of interventions in acute traumatic brain injury that's ever been undertaken. He identified 208 randomised controlled trials, of which 191 have been completed. And of those, over 2/3 had fewer than 100 patients. The median number was 66 patients, and 72% were single centre. Again, 2/3 were assessed as being at high risk of bias in their randomisation allocation concealment. So he was left with 26 randomised controlled trials that were assessed as being robust in that they were multi-centre, they had sample sizes that were over 100, and they were assessed as low risk of bias. Unfortunately, only 7 of those 26 actually showed a difference in patient-centred outcomes. Now, as clinicians, we need guidelines to distill the vast array of evidence that's available, and the Brain Trauma Foundation guidelines are the most widely recognised international guidelines for the management of severe TBI. And not surprisingly, the level of evidence that's available to provide high-level recommendations is low. So using slightly different methodology, the BTF identified 189 studies, of which only 5 were high quality by their assessments. And with those, they were able to only develop one level 1 recommendation, which was not to use corticosteroids, high-dose corticosteroids following severe traumatic brain injury. And the vast majority of their recent recommendations were low level. So it's fair to say that, that the quality of evidence overall to guide the clinicians in the management of severe traumatic or traumatic brain injury in general is low, and that we need to figure out ways to enhance this. So getting back to the 5 trials that the Brain Trauma Foundation identified as being of high quality, 4 of these were actually conducted by clinical trials networks, and I'll highlight the DECRA trial, which was conducted by the ANZIC CTG. DECRA, or decompressive craniectomy in severe diffuse traumatic brain injury, was a randomised controlled trial conducted over 8 years and enrolled only 155 patients. We don't have it quite so easy as the obstetrician researchers. It's very hard to recruit into TBI trials. It's a very heterogeneous condition. There is enormous variation between sites, and the DECRA trial was a landmark study that showed a surgical technique used to reduce the pressure within the skull after an impact causing swelling, which was shown to be effective at reducing the pressure, actually unexpectedly caused harm, with a greater proportion of patients ending up with severe disabilities. Now, with all due respect to our American colleagues, this was not a welcome result, and although DECRA was published in the New England Journal and had very high internal validity, there was a great deal of editorialising about the perceived flaws of this study, and it's been gratifying very recently to see a larger study still conducted over 10 years essentially confirm the results of the DECRA trial. The other studies that were considered high quality and for inclusion in the Brain Trauma Foundation guidelines were the CRASH study, which I alluded to before, comparing high-dose corticosteroids to placebo in all severities of traumatic brain injury. They recruited across 42 countries, 239 sites, and showed unequivocally that high-dose corticosteroids are bad for you, with increasing mortality following TBI. The SPIRIT ICU was conducted with a French clinical trials network, and BEST TRIPS was a collaboration between Seattle, Argentina, Bolivia and Ecuador, and has produced another landmark study. The one study that I would identify from these 5 that were considered high quality that was not conducted by a clinical trials network was a study of very early hypothermia following severe traumatic brain injury. Cooling is thought to reduce the swelling in the brain and has been shown in animal models to be beneficial. And there is ongoing uncertainty about its benefit in humans. Unfortunately, the NABISH-2 study, which was NIH funded and had a pretty well-conceived protocol, had to be stopped early because of a lack of sites and a lack of patient recruitments. And indeed, 51% of their patients were recruited from one site. So the ANZIC CTG is picking up the slack on this, and we are currently approaching completion of recruitment for the POLAR trial, which is a similar study of early hypothermia following severe traumatic brain injury. While it's important that we continue to conduct randomised controlled trials in clinical trial networks, as has been identified, randomised controlled trials are very difficult, and there are other means by which the truth can be attained or at least visualised. And the traumatic brain injury research community has been very active in exploring these other opportunities through the networks. And I would highlight the work of the International Initiative for Traumatic Brain Injury Research, which is a collaboration of other networks around the world. There are networks within networks in this program. So the ANZIC CTG is involved, the Canadian Critical Care Trials Group are involved, and probably the biggest component of this group, which is funded through the European Community, the NHMRC, the NIH and the CIHR. The biggest tranche of funding has come to the Centre TBI component, which is led by Andrew Mars in Antwerp and David Menon in Cambridge. And the Centre TBI is the main component of this part of the INTBEAR community is a comparative effectiveness research study collecting extremely detailed, nuanced information from across Eastern and Western Europe. I should also mention that China is involved in collecting data for the INTBEAR community, and by identifying practice variation across Western and Eastern Europe, the Centre TBI investigators will undertake comparative effectiveness research, and Australia is contributing to that data set as well through a NHMRC partnership grant and the AusEnter study. So where does this leave us with translation? And I've heard a number of presentations today speak about how the high quality study was published in a high impact paper, a high impact journal, was then picked up by the well established and highly regarded guidelines, and then that's been the end of the narrative. So the issue that we're dealing with and that I'm trying to deal with in my PhD is that there is a lack of data that actually shows, observational data that shows practice change in response to trial publication. With a review that we published late last year and updated a couple of months ago, we've attempted to address this issue, looking at 22 observational studies assessing the implementation of 13 recommendations. And while the adherence to the recommendations, which were predominantly the Brain Trauma Foundation guidelines, but also some NICE guidelines, the adherence varied considerably. However, there seemed to be a signal that recommendations based on high quality evidence, i.e. that conducted by clinical trial networks, were more likely to be implemented. And gratifyingly, better adherence was associated with better patient outcomes. So my interpretation of that is that networks can improve implementation indirectly by generation of higher quality evidence. But what about direct translation? Can networks actually encourage the practitioners within them to better implement their research findings? And I was particularly struck by Paul Miles's discussion earlier about being a clinician researcher and how important that was. And I was also reminded of a legend of the intensive care community in Australia, Bob Wright, who said of clinician researchers that they are neither good clinicians nor good researchers. I have to say that I think he was dead wrong on that. The features of clinician researchers and hospitals that are affiliated with clinical trials networks that might encourage implementation are that clinician researchers are at the coalface. They know what the questions are that have to be asked, and they know what interventions are practical and applicable and potentially available. They're also invested in seeing the research results disseminated and implemented, and because they're often opinion leaders, they can provide some spillover to other clinicians to encourage uptake of latest evidence. The clinical trial networks, hospitals are usually academic affiliated, and so there's educational support to provide improved understanding of study design, strengths and limitations. But the question remains, does this potential translate into improved implementation? And I have to say that in the setting of neurotrauma, I still don't know the answer. There will be more data becoming available in the next couple of months that I'm sorry I don't have for you today. There is suggestion from other settings that engagement with provider-based research networks improves the implementation, and specifically in oncology and in public health, and also in dentistry industry, interestingly. In the studies of adherence to guidelines in neurotrauma to date, hospital characteristics, and particularly whether the hospital is a participant in a clinical trial network, has not been included. And given that particularly with the ANZIC's clinical trials group, there is very prevalent among tertiary and quaternary institutions in Australia, I'm not sure that we're ever going to be able to do a direct comparison to see whether non-affiliated institutions are different from affiliated institutions. But we can try and extrapolate from other critical care data, and this is my last slide. So this is the fluid TRIPS study undertaken by Naomi Hammond at Royal North Shore and the the ANZIC CTG. And what she's shown quite neatly here is the use of two different types of intravenous fluid resuscitation. So starting back in 2007, they assessed the use of fluids right up to 2013 and mapped that against the landmark papers that were studied in that time. And this is data from ANZIC CTG centres. And what you can see is that there has been dramatic shifts in practice that generally align with the shift in the evidence base in that time. So I find that quite encouraging. In conclusion, I think we would agree that high quality evidence should be the currency of translation. I would contend that clinical trial networks are where this money is made and probably where it should be spent in order to achieve best patient outcomes. Thanks very much.
So, time for one question.
Dash, you showed us some trials that were done in other countries, including the ones in Australia, the 5 pivotal studies. Was the uptake different in Australia when studies were done overseas, and should we have been collaborating, the CRASH study, for example? Do you see that the involvement in the study is critical to change in practice, or will it happen anyway?
Yeah, I think that that's a great question, John, and it relates to a question that Jonathan was asked as well, whether participation with the USA, for example, might have encouraged uptake of the prompt results. And I think the same would have been true for DECRA had US sites. I feel like they would have been more receptive to the unexpected and unwelcome results. But unfortunately, I don't have the data to support that feeling, and the same is true for studies conducted overseas and their impact in Australia, although CRASH did have Australian sites. I think Gold Coast participated in that as well as one or two other sites. Thanks very much.